Good morning, everyone, and welcome to the pharmacology class. And today's topic is vasodilators and the treatment of angina pectoris. And angina pectoris is a chest pain caused by the accumulation of metabolites resulting from myocardial ischemia. So the main classes of the drugs that used for the treatment are nitroglycerin and the derivatives of the nitroglycerin, and also the beta blockers and calcium channel blockers. And beta blockers are also not dilating the vessels, but very useful for the prophylaxis, and calcium channel blockers are also mostly used for the prophylaxis. And the reasons for the angina is a obstruction of the coronary vessels. So the inadequate blood flow results in the classic angina or the effort angina, which taking place when under the pressure or the physical under this physical exercise. And also there is a vasospastic angina, or that is also called a variant angina, and the reason for this, so this angina can be at rest or even at rest, and the reason is the spasm of the vessels. Another name for the vasospastic angina is a Prinzmetal angina. And the leading reason for the angina pectoris is a imbalance between the oxygen requirement and the oxygen delivery. In effort angina, this imbalance occurs when myocardial oxygen requirement increases, especially during exercise, and the coronary blood flow should increase, but it is not increasing because of the ischemia. And the resulting ischemia is usually making a pain, and pain is very severe, and that is why the name is angina pectoris, like the frog is sitting in the lungs. And the sometimes the angina is without pain, like and also sometimes the angina is because of the decrease of the delivery of the oxygen, not the increase of the oxygen demand, and that is usually during the vasospastic angina. And the third type of the angina is unstable angina or acute coronary syndrome. And this angina occurs at rest, and uh, that can be result of the previous uh, stable angina. And uh, the reason for the unstable angina is increased coronary artery resistance, or the clot occurring uh, in those vessels. And uh, the duration of the unstable angina is different, but the unstable angina can lead to the myocardial infarction and death, and that is why it's considered an emergency state. Uh, so to treat the angina, any type of the angina can be treated by decreasing oxygen demand or increasing oxygen delivery. And in effort angina, oxygen demand can be reduced by decreasing cardiac work, or by shifting myocardial metabolism to substrates that require less oxygen per ATP produced. In vasospastic angina, spasm of coronary vessels can be reversed by nitrate or calcium channel blocking vasodilators, but not the beta blockers, because beta blockers does not relax the vessels. And lipid lowering drugs, especially statins, are important in the treatment of the atherosclerotic disease, and that in unstable angina, to usually the increase of the oxygen delivery and decrease of the oxygen demand is required. So the major determinants for the myocardial oxygen consumption are intraventricular pressure, ventricular radius, wall thickness, heart rate, and contractility. So the effect of arterial blood pressure is mediated through its effects on wall stress. As a consequence of its continuous activity, the heart oxygen is relatively high, and it contracts approximately 75% of the available oxygen, even in the absence of stress. The myocardial oxygen requirements increases when there is an increase in heart rate, contractility, arterial pressure, or ventricular volume. These hemodynamic alterations frequently occur during physical exercise and sympathetic discharge, which often precipitate angina in patients with obstructive coronary artery disease. Drugs that reduce cardiac size, rate, or force reduce cardiac oxygen demand. Thus, vasodilators, beta blockers, and calcium channel blockers have predictable benefits in angina. The increased demand of oxygen in the normal heart is met by augmenting coronary blood flow Coronary blood flow is directly related to the perfusion pressure or aortic diastolic pressure and the duration of diastole. Because coronary flow drops to negligible values during systole, the duration of diastole becomes a limiting factor for myocardial perfusion during tachycardia. Coronary blood flow is inversely proportional to coronary vascular resistance, and resistance is determined mainly by intrinsic factors including metabolic products and autonomic activity, and by pharmacological agents. Damage to the endothelium of coronary vessels has been shown to alter the ability to dilate and to increase coronary vascular resistance because the endothelium is synthesizing the nitrous oxide that is uh, most potent intrinsic vasodilating factor. So the factors that in increase and decrease the vascular tone are shown at this picture, and the peripheral arterial and venous tone play a role in determining myocardial wall stress. Oh, arterial tone directly controls peripheral vascular resistance and thus arterial blood pressure. In systole, intraventricular pressure must exceed aortic pressure to eject blood. Arterial blood pressure thus determines the systolic wall stress in an important way. Venous tone determines the capacity of the venous circulation and controls the amount of blood sequestered in the venous system versus the amount returned to the heart. Venous tone thereby determines the diastolic wall stress. The regulation of smooth muscle contraction and relaxation is shown here schematically, and the there are several ways in which the vascular smooth muscle can relax. So the first is increase in cyclic guanosine monophosphate, and cyclic guanosine monophosphate facilitates the dephosphorylation of myosin light chain, preventing the interaction of myosin with actin. So this is cyclic guanosine monophosphate, and that is activate the myosin light chains, and that leads to relaxation. Important molecular donors for nitric oxide include nitric oxide and the organic nitrates used in Angina. So the second way is decreasing intracellular calcium. The calcium channel blockers cause vasodilation because they reduce intracellular calcium. So these calcium channel blockers block the calcium channel that allows calcium to pass inside the cell, and the calcium is a uh, leads to the activation of the light change of the myosin through the several steps, and that leads to the contraction. That is why reducing calcium will reduce contraction, so that is relaxation. Beta blockers and calcium channel blockers also reduce calcium influx in cardiac muscle fibers, thereby reducing rate, contractility, and oxygen requirement under most circumstances. Third way is stabilizing or preventing depolarization of the vascular smooth muscle cell membrane. Uh, uh, So then a new class of the drugs, potassium channel openers such as minoxidil sulfate, increase the permeability of potassium channels, probably ATP dependent type, and uh, some new drugs are also used for angina and may act by this mechanism. So potassium channels, so here are the activators, potassium channels, and potassium is going out. So, and the fourth is increasing cyclic adenosine monophosphate in vascular smooth muscle cells. So increase in the cyclic adenosine monophosphate, for example, by beta 2 agonist, increases the rate of the inactivation of myosin to myosin uh, phosphate that inactivates the light change kinase, and this enzyme will promote the phosphorylation of the myosin light change uh, to the and to promote the reaction with the actin and contraction. So the beta agonists are not used in angina because they cause too much cardiac stimulation, but the phenoldiazepam and the one agonist used in hypertensive emergencies. So the three groups of drugs that are used traditionally for the treatment of angina are the organic nitrates, beta blockers, and calcium channel blockers. And in some patients, the nitrates and calcium channel blockers may cause a redistribution of coronary blood flow and increase oxygen delivery to ischemic tissue. In vasospastic angina, uh, uh, the nitric oxide and calcium channel blockers increase myocardial oxygen delivery by reversing coronary artery spasm. And the first class is, so the most commonly used class is nitrates and derivatives of the nitric oxide, and these agents are the esters of the polyalcohols, and nitroglycerin is the prototype of the group, and nitroglycerin is used mostly in the to produce dynamite, that is that is an explosive substance. However, the nitroglycerin formulation for the uh, treatment is not explosive, and sublingual forms are very conventional, uh, and the nitroglycerin can lose potency when stored uh, because of the uh, volatilization and absorption to plastic surfaces. Therefore, it should be kept in tightly closed glass containers. And it is not sensitive to light. So, the difference in the drugs in this group are only in pharmacokinetics, and because the mechanism of action is the same, and the pharmacokinetics depends on the type of the drug, because liver contains high capacity organic nitrate reductase that removes nitrate group in a stepwise fashion from the parent molecule and ultimately inactivates the drug. And for this reason, the oral bioavailability of the traditional organic nitrates like nitroglycerin and isosorbide dinitrate are low and usually are about 20%. For this reason, the sublingual route, which avoids the first pass effect, is preferred for achieving a therapeutic blood level rapidly. Nitroglycerin and isosorbide dinitrate both are absorbed efficiently by the sublingual route and reach therapeutic blood levels within few minutes. However, the total dose administered by this route must be limited to avoid excessive effect. Therefore, the total duration of action is brief, about half an hour, and when a much longer duration of action is required, oral preparations can be given that contain an amount of drug sufficient to result in sustained systemic blood levels of the parent drug plus active metabolites. Other routes of administration available for nitroglycerin include transdermal patch and buccal absorption from slow-release preparations. Amyl nitrite and related nitrites are highly volatile liquids, and amyl nitrite is available in fragile glass ampoules packed in a protective cloth covering. The ampoule can be crushed with the fingers, resulting in rapid release of vapors inhalable through the cloth covering. The inhalation route provides very rapid absorption and, like the sublingual route, avoids the hepatic first-pass metabolism. Because of its unpleasant odor and short duration of action, amyl nitrite is now obsolete for angina. Once absorbed, the unchanged nitrate compounds have half-lives of only 2 to 8 minutes. The partially denitrated metabolites have much longer half-lives, up to 3 hours. Uh, the metabolites of the nitroglycerin, uh, the 1,2-dinitro derivative, has significant vasodilator efficacy and probably provides most of the therapeutic effect when administered orally. And the 5-mononitrate metabolite of isosorbide nitrate is an active metabolite of the drug and is available for oral use as isosorbide mononitrate, and it has a bioavailability of 100%. The drugs are excreted by the glucuronide derivatives and usually as a denaturate metabolite by the kidney. The mechanism of action of nitroglycerin is still not fully understood, and there is general agreement that the drug must be bioactivated with the release of nitric oxide. Unlike the nitroproside and some other direct nitric oxide donors, nitroglycerin activation requires enzymatic action. Nitroglycerin can be denatured by glutathione or esterase. Mitochondrial enzyme aldehyde dehydrogenase isoform 2. Then can also activate the nitroglycerin and to make nitric oxide to release. The selectivity of glutathione esterase and aldehyde dehydrogenase isoform 2 may be the more important enzyme for different organic nitrites, suggests that that may be more important for inactivation of the nitroglycerin. After that, the pre-nitrate ion is released, which is converted to nitric oxide, and nitric oxide combines with the hem group of the soluble guanylyl cyclase. So after the release of the nitric oxide, it combines with the guanylyl cyclase and formates the cyclic that promotes formation of the cyclic guanosine monophosphate. That is first step to the muscle relaxation. The production of prostaglandin E2 or prostacyclin and membrane hyperpolarization will also be involved. So there is no evidence that autonomic response receptors are involved in the primary nitrate response. However, autonomic reflex responses develop when hypotensive doses are given. That is very common. As described, the tolerance is an important consideration in the use of nitrates. Although tolerance may be caused in part by a decrease in T sulfhydryl groups, for example on cysteine, it can be only partially prevented or reversed with a sulfhydryl regenerating agent. Increased generation of oxygen-free radicals during nitrate therapy may be another important mechanism for tolerance. Recent evidence suggests that diminished availability of calcitonin-related peptide is also associated with nitrate tolerance. So nitroglycerin also relaxes Other smooth muscle are regardless of the cause of the existing muscle tone, and it has particularly no direct effect on cardiac or skeletal muscles. Uh, so the smooth muscles are relaxed in response to the nitroglycerin, and veins are responding at low concentration, arteries at slightly higher concentrations. The epicardial coronary arteries are also sensitive, but concentration uh, uh, can be prevented significant dilation. Uh, and on the other hand, eccentric lesions permit an increase in flow when nitrates relax the smooth muscle on the side away from the lesion. Arterioles and precapillary sphincters are dilated least, partly because of reflex responses and partly because different vessels vary in their ability to relax nitric oxide from the drum. Uh, so the primary result of nitroglycerin is a relaxation of veins with increased venous capacitance and decreased ventricular preload. Pulmonary vessels, uh, pressures and heart size are significantly reduced. In the absence of heart failure, cardiac output is reduced because venous capacitance is increased. Orthostatic hypotension may be marked and syncope can result. Dilation of large epicardial coronary arteries may improve oxygen delivery in the presence of eccentric atherosclerosis, and temporal artery pulsations and a throbbing headache associated with meningeal artery pulsation are common effects of nitroglycerin and amyl nitrite. In heart failure, preload is often abnormally high. Other nitrates and other vasodilators are, by reducing preload, may have a beneficial effect on cardiac output in these conditions. The indirect effects of nitroglycerin consist of these compensatory responses evoked by baroreceptors and hormonal mechanisms responding to decreased arterial pressure. This often results in tachycardia and increased cardiac contractility. Retention of salt and water may also be significant, especially with intermediate and long-acting nitrates. The compensatory response contributes to the development of tolerance. In normal subjects without coronary disease, nitroglycerin can induce a significant increase in total coronary blood flow. In contrast, there is no evidence that total coronary flow is increased in patients with angina due to atherosclerotic obstructive coronary artery disease. However, some studies suggest that distribution of coronary flow from normal to ischemic regions may play a role in nitroglycerin's therapeutic effect. Nitroglycerin also exerts a weak negative inotropic effect on the heart via nitric oxide. Relaxation of smooth muscles of the bronchi, GI, and genitourinary tract has been demonstrated experimentally. Because of their brief duration, these actions of the drug are rarely of any clinical value. During recent decades, the use of amyl nitrite and isobutyl nitrite by inhalation and as recreational sex-enhancing drugs has become popular with some uh, segments of the population. Drugs readily release nitric oxide in erectile tissue as well as smooth muscle and activate guanylyl cyclase. The resulting increase in cyclic guanosine monophosphate causes dephosphorylation of myosin light chains and relaxation, which enhances erection. The pharmacologic approach to erectile dysfunction is discussed uh, will be discussed later. So the nitric oxide released from nitroglycerin stimulates guanylyl cyclase in platelets as in smooth muscle. The increases in the cyclic guanosine monophosphate that results uh, is responsible for a decrease in platelet aggregation. Unfortunately, recent prospective trials have established no survival benefit when nitroglycerin is used in acute myocardial infarction. In contrast, intravenous nitroglycerin may be of value in unstable angina, in part through its action on platelets. Nitric ion reacts with hemoglobin to produce methemoglobin. Because methemoglobin has a very low affinity for oxygen, large doses of nitrates can result in pseudocyanosis, tissue hypoxia, and death. Fortunately, the plasma level of nitric oxide resulting from even a large dose of organic and inorganic nitrates is too low to cause significant methemoglobinemia in adults. In nursing infants, the intestinal flora is capable of converting significant amounts of inorganic nitrates from, for example, from well water to nitrate ion. In addition, sodium nitrite is used as a curing agent for meats, for example, corned beef. Thus, inadequate exposure to large amounts of nitrite ion can occur and may produce serious toxicity. One therapeutic application of this otherwise toxic effect of nitrite has been discovered. Cyanide poisoning results from complexing of cytochrome ion by the cyanic ion. Methemoglobin iron has a very high affinity for cyanide, thus administration of sodium nitrate soon after cyanide poisoning exposure regenerates active cytochrome. The cyanomethemoglobin produced can be further detoxified uh, by the intravenous administration of sodium thiosulfate. This results in formation of thiocyanate ion, a less toxic ion that is readily excreted. Methemoglobinemia, if excessive, can be treated by giving methylene blue intravenously. This antidotal procedure is now being replaced by hydroxycobalamin, a form of vitamin B12, which also has a very high affinity for cyanide and converts it to another form of vitamin B12. The major acute toxicities of organic nitrates are direct extensions of therapeutic vasodilation, orthostatic hypotension, tachycardia, that is reflex, and throbbing headache. Glaucoma, once thought to be a contraindication, does not worsen, and nitrates can be used safely in the presence of increased intraocular pressure. Nitrates are contraindicated, however, if intracranial pressure is elevated. Rarely, transdermal nitroglycerin patches have ignited when external defibrillator electroshock was applied to the chest of patients in ventricular fibrillation. Such patches should be removed before use of external defibrillators to prevent superficial burns. With continuous exposure to nitrates, isolated smoked muscle may develop complete tolerance, this tachyphylaxis, and the intact human becomes progressively more tolerant when long-acting preparations like oral and transdermal patches or continuous intravenous infusions are used for more than a few hours without interruption. The mechanisms by which tolerance develops are not completely understood. As previously noted, diminished release of nitric oxide resulting from reduced blood bioactivation may be partially responsible for tolerance to nitroglycerin. Systemic compensation also plays a role in tolerance in the intact human. Initially, significant sympathetic discharge occurs, and after one or more days of therapy with long-acting nitrate, retention of salt and water may reverse the favorable hemodynamic changes normally caused by nitroglycerin. Tolerance does not occur equally with all nitric oxide donors. Nitric oxide, for example, retains activity over long periods, and other organic nitrates appear to be less susceptible than nitroglycerin to the development of tolerance. In cell-free systems, soluble guanylate cyclase is inhibited, possibly by nitrosylation of the enzyme, only after prolonged exposure to excessively high nitroglycerin concentration. In contrast, treatment with antioxidants that protect the uh, ALDH2 and similar enzymes appears to prevent or reduce tolerance. This suggests that tolerance is a function of diminished bioactivation of organic nitrates and, to a lesser degree, a loss of soluble guanylate cyclase responsiveness to nitric oxide. Continuous exposure to high levels of nitrates can occur in the chemical industry, especially where explosives are manufactured. When contamination of the workplace with volatile organic nitrate compounds is severe, workers find that upon starting their work week they suffer headache and transient dizziness, that is called Monday disease. After a day or so, these symptoms disappear owing to the development of tolerance. Over the weekend, when exposure to the chemicals is reduced, tolerance disappears, so symptoms recur each Monday. Other hazards of industrial exposure, including dependence, have been reported. There is no evidence that physical dependence develops as a result of the therapeutic use of short-acting nitrates for angina, given in large doses. The nitrosamines are small molecules with the structure of R and NO formed from the combination of nitrates and nitrites with amines. Some nitrosamines are powerful cancerogens in animals, apparently through conversion to reactive derivatives. Although there is no direct proof that these agents cause cancer in humans, there is a strong epidemiologic correlation between the incidence of esophageal and gastric carcinoma in the nitrate content of food in certain cultures. Nitrosamines are also found in tobacco and in cigarette smoke. There is no evidence that the small doses of nitrates used in the treatment of angina result in significant body levels of nitrosamines. So I think that is all for today, and thank you for your attention, and see you next week.
Thank you too. See you. Goodbye.
Bye bye.